Good afternoon and welcome. Thank you for joining us for today's training, an overview of bipolar disorder for nursing facility staff, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence. At this time, it is my pleasure to introduce our presenter for today, Mr. Brian Stevens. Mr. Stevens is a licensed professional counselor and the founder and CEO of Talk Forward, which provides psychotherapy and executive consulting services. Brian has practiced in behavioral health for the past 30 years and has extensive executive management experience. And now I'll turn it over to Brian to begin the presentation.
Hello, I'm so excited to be talking to you today. We are going to be developing an understanding of bipolar disorder today. This is really, think about this as a primer. We're going to be able to recognize and understand some signs and symptoms of both mania and depression, and then be able to learn an appropriate response of engagement for residents. So talking about what is bipolar disorder, many of you may have heard of manic depressive illness or manic depression. This is what is now called bipolar disorder. It's a mental illness that causes an unusual shift in a person's mood, energy, activity levels, and concentration. And these shifts can make it difficult for people to carry out their day-to-day tasks. It is classified as a type of mood disorder, like depression. It is lifelong. What we see for people that have bipolar disorder is that this is something that goes on throughout their life, though recovery is certainly possible with interventions. We'll talk about those. We often see it diagnosed in late adolescence or early adulthood. However, it really can be diagnosed at any time in life. Symptoms might have been present, but they were not understood as a problem for the individual. The two basic types of bipolar disorder is bipolar 1 and bipolar 2. A bipolar 1 disorder is defined by having at least once in your lifetime a manic episode. And a manic episode's got to be a high energy state that lasts for at least 7 days, where the person's having that experience for nearly every day for most of the day. Or if they have manic symptoms that are so severe that they need immediate medical care, such as a hospitalization to keep them safe. We usually see depressive episodes occur as well, and these can last at least 2 weeks, if not longer. I've had some clients that, they may have a bipolar peak once a year and then be depressed most of the rest of the time. It is possible to have episodes of depression with mixed features. These means having some symptoms of mania at the same time you're depressed, and we'll talk a little bit more about those. If somebody has 4 or more episodes of mania and depression within 1 year, that's called rapid cycling. And rapid cycling is one of those things that's misunderstood. A lot of people say, oh, I'm rapid cycling, when what they're really talking about is they're having mood lability. So people do not rapid cycle between mania and depression over the course of a day. What we see is these periods last several days. A rapid cycler could bounce around multiple times in a year, obviously more than 4. But if it's somebody's mood's wildly swinging throughout the day, that's more of a mood lability. Bipolar 2 disorder is a pattern of depression and hypomanic or a submanic episode. And we'll talk about the differences between these here in a minute. The hypomanic episodes are generally less severe than the manic episodes that we see in bipolar 1 disorder. I kind of like using this chart to talk about mood because I'm big into visual charts. So what we have in the middle is normal range. The normal range mood, it's that green line I put in there, and that's the normal ups and downs of mood. Some days we feel better, some days we feel worse. But we tend to bounce around in between those lines. When we look at bipolar 1, that's somebody who can have a full-blown manic episode, so all the way up to the top of the list, top of the chart. And then they can crash all the way down to full-blown depression. So the individual bipolar 1 runs the full gamut. Bipolar 2, by contrast, that's the orange line, can go up to the hypomanic level and maybe have some hypomania and then also crash down into depression. So there's a big difference. We also kind of see on this chart, we see dysthymia and depression. And so dysthymia is a low grade mood, and often people will kind of maintain who have that low level of depression. They'll maintain that for quite some time, often years. I've seen people take an antidepressant with dysthymia and they're suddenly like, oh, I didn't know I could feel this good. And then, of course, depression, where we talk about is the high levels of depression that we're familiar with. Somebody who has unipolar depression is simply, they come down into depression and hopefully back up into a normal range. So let's talk a little bit now about recognizing what a manic episode looks like. Manic episodes are often characterized by things like racing thoughts. One of the things I've found with people in doing an intake, I'll ask them, have you ever experienced racing thoughts? And if people haven't, they'll be like, I don't understand what you mean. But if they have, they'll say yes. Somebody who is manic may report feeling very up, high energy, elated, euphoric. They may also appear to be extremely irritable or touchy to other people. Generally can have a decreased need for sleep or may not even sleep at all. Talking about a bunch of different things at once, bouncing around that tangential speech or flight of ideas, may have very pressured speech, can try to do many things at once without getting tired. We can see like an excessive appetite for food, for drinking, sex, other pleasurable activities such as gambling. They may have feelings of being unusually important or talented or powerful. And one of the things we can see with mania is some symptoms of psychosis, such as delusional thinking and hallucinations when it gets pretty severe. And some of this is probably linked to the psychosis, linked to the fact that the person's no longer sleeping. And as we know, if we don't sleep for long enough, we can have an induced psychosis. So hypomania is that lower level submania that's less intense than full-blown mania. And often hypomania, the person feels good. They have good mood. They have good energy. They feel like they're able to get things done. They have a decreased need for sleep and are still able to function. They feel like they're more creative. They actually can be more creative. Thinking faster, often can have some pressured speech, and generally don't recognize anything is wrong because hypomania feels good to the person experiencing it. And this hypomania may be one of the reasons why we struggle so much with having people with bipolar disorder maintain their medication regimen, because they miss the hypomania. Frankly, if we could put this in a bottle and sell it, I think it'd be very popular because our society really rewards hypomania. Depression, then, we often see people can report feeling very down. They can feel sad or anxious, or may say, I don't have any feelings at all, like depression just wipes out their feelings. They can be slowed down, maybe a sense of restlessness. Sleep can be, I have trouble falling asleep. I wake up too early, sleeping too much. Often we see in depression an inversion of sleeping, wanting to sleep during the day instead of at night. They may talk slowly, really have nothing to say, or seem to be forgetful. Certainly, depression can lead to having trouble to concentrating or making decisions, not really having the energy or motivation to do even simple things, lack of interest in pleasurable activities, and in extreme cases, feeling hopeless, worthless, or thinking about death or suicide. So with dysthymia, which is, again, this is that dysthymia is that low-level depression. It's diagnosed, it's called persistent depressive disorder. It was formerly dysthymic disorder. And that's characterized by chronic low-level depression. It's not as severe as depression, but often is longer lasting than a major depressive disorder. A diagnosis of persistent depressive disorder requires having experienced a combination of depressive symptoms for 2 years or more. So as we see, that's a long-term diagnosis. And finally, I want to just talk a little bit about a mixed episode, because mixed episodes are actually, in some ways, the most dangerous state to an individual with bipolar disorder. So individuals can have both manic and depressive symptoms in the same episode. So this means mixed features. The problem here is somebody can have the mood state of depression, the hopelessness of depression, the lack of pleasure of depression. At the same time, unlike somebody with full-blown depression that doesn't have the energy, doesn't have motivation for action, that person has the energy of mania, which means they have the energy for action. So you can have people who are depressed in their mood with the energy of mania, meaning they have the energy to act out those suicidal thoughts. So mixed states are actually people at high risk for suicide. And that's actually one of the interesting things I want to mention on that is sometimes what we look at when people are depressed and we first give them antidepressants, that's that same danger window where the antidepressants may give them energy before they give them increased mood. So ways that we can support residents experiencing symptoms of mania. Be patient. Gently redirect them back on topic. Try not to respond to their irritability with irritability. Attempt to redirect some physical activity to burn energy. Then get some of that energy out. That's fantastic. Monitor sleep. If they're not getting any sleep, that can lead to psychotic. If somebody is psychotic, we want to avoid direct confrontation. Don't want to deny hallucinations or delusions. Want to try to go with that perceived reality when possible, trying to ensure safety first. Treatment of bipolar disorder, of course, requires a full assessment from medical staff. We want to have, if somebody's showing signs of mania, have that assessment take place. And what might they do? Medications may be used in the short term and for ongoing care. Often for people with bipolar disorder, we see some sort of ongoing mood stabilizer being used. So you might see lithium, Depakote, or even some of the atypical antipsychotic medications being used for that, such as Abilify. You want to see tests to rule out other medical conditions. And there may need to be a change in medications. Sometimes what we can see is if we diagnosed somebody with a depressive disorder, what may happen is they're given an antidepressant and the antidepressant stimulating, and so it causes a manic episode. The other thing, of course, we sometimes see with medications is that bipolar depression is a little bit different than regular depression and can be resistant to antidepressants. So usually that mood stabilizer is the most critical component. And again, the doctors will be the ones making that determination, or our practice extenders, PAs and APRNs. Of course, there's non-pharmacological interventions, I think, that are very critical to helping somebody's daily living. Social skills training can be very important. Coping skills, helping people be able to recognize when they're having mania, when something's going on, warning signs for them. I remember having a client who was not able to take her mood stabilizing meds at the time because she was pregnant. She'd gotten pregnant while she was manic, and having some increased libido and sexual activity. So we monitored her and used things like how she dressed, what makeup she chose. It's cues for her to say, okay, I'm having some mania as we work to get through it. It's kind of an example of things you can help people see. We want to, I think, with coaching, be problem and symptom focused with our interventions. And if somebody is having mania, how can we kind of coach them in the right direction? Talk therapy, of course, and I worked as a therapist, I worked with a number of people who've had bipolar over the years. How do we manage it? What does it look like? What are things they can do? And what does it stir up? Because frankly, a lot of people will be very embarrassed about how they were thinking, what they were doing in a full-blown manic episode. They're like, that's not me. That's not how I want to be. They also may miss the hypomania, though, and be like, well, I remember being told by somebody, well, I stopped taking my medicine because I'm not as excited as I'd like to be. It's like, okay, well, being that excited is not sustainable in your brain. So what can you do today? Well, number one, you're doing it right now for you. So you're training yourself. You want to train the assessment team on the proper bipolar diagnostic criteria. So, and that includes everybody in the interdisciplinary team, your physician, your nurses, your social workers, your techs. What we want people to do is be able to recognize, right, at every level, what are signs and symptoms that are going on, and what are some supportive responses, right? We need to understand if we have a resident, it's like, boy, they're really not sleeping much at night, and this has been going on for several days. Because ideally, if somebody's on a trajectory for a full-blown manic episode, if we can have an intervention ahead of time, tweak their medication, help them get some more sleep, that's going to be better for the resident and everybody around them. So we definitely want to make sure that if somebody does have a diagnosis of bipolar disorder, let's say they come with a diagnosis of bipolar disorder to the facility, or they receive it while they're there, want to make sure that they've got the appropriate level of counseling and psychiatric support. If we've diagnosed somebody with bipolar disorder, the chances are they're not taking a mood stabilizer, they're going to have an episode. And we want to make sure that the team is communicating, symptoms are communicated. I'm seeing changes. We want to have that at shift report. We're definitely making sure that we understand we're looking at somebody's changes. We want to look at the stimuli in the nursing facility. So any residents that are having an episode of mania are going to benefit from having a routine and calm and stable environment around them. And that is really important, because they're going to have a lot of energy, a lot of agitation, a lot of anxiety. Having the routine and calm can be very important. And I think this is one of those things where we just want to make sure we look at it, always looking at what's the experience like for the residents. Of course, planning activities when we want to work with bipolar clients with a bipolar diagnosis when they're not manic. An effective sleep schedule is critical. I've seen clients who are taking their medicine, they're otherwise being compliant, but they travel. Something happens that disrupts their sleep pattern, and that triggers a manic episode. So helping people have that good, solid, regular sleep for the residents when they have a bipolar disorder diagnosis is really helpful for their mental health hygiene. Having a plan to manage the client's energy, having some basic exercise, a little bit of cardio, something so if they start getting excess energy, they've got a way to burn it off. And that also becomes part of the diagnostic criteria. If they say, hey, I'm doing my exercises, but I still have a lot of extra energy. And of course, finally, we want to make sure that the person's got choices, and those choices are part of the resident's care plan. Because that care plan, right, the more buy-in they have for that care plan, the better off they are, and the more compliant that we're going to see them be. So, with that, I want to say thank you for being with me today to do this high-level review of bipolar disorder and what we see in residents and homes. And now I'm going to turn it back over to Derek for some additional housekeeping.